Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 550 of our pharmacotherapy series, which majors in bipolar disorder. The first case reads, RLT, a 33-year-old man, has been treated for an episode of acute mania with lithium 600 mg twice a day for 3 weeks. He is no longer overtly manic. Because of RLT's past episodes of depression and mania, his physician decides to institute prophylactic, that is maintenance, lithium therapy. What are the goals of maintenance lithium therapy for RLT? How should he be monitored during this maintenance phase? How long should RLT be maintained on lithium? Recurrent episodes are associated with decreased quality of life, poorer response to treatment, longer hospitalizations, and cognitive impairment. Thus, early maintenance, that is prophylactic, treatment is indicated to prevent disease progression. Appropriate goals for maintenance therapy include an increase in the interval between episodes, a decrease in the frequency of episodes, and a reduction in the duration and severity of mood episodes. In most cases, patients will have been started on an acute treatment for a manic or depressive episode. These agents should generally be continued because abrupt switches in medications may predict poorer treatment outcomes. We will now look at lithium. The aforementioned meta-analysis of long-term lithium therapy for relapse prevention in bipolar disorder included 5 randomized, placebo-controlled studies. Although lithium did not effectively reduce the risk of relapse to depression, it did reduce the risk of relapse to any mood episode, risk ratio 0.66, and to manic episodes specifically, risk ratio 0.62. The average risk of relapse to any mood episode on lithium was 40% versus 60% for placebo. The average risk of relapse to a manic episode was 14% for lithium versus 24% for placebo. In the case of RLT, he should be continued on lithium. The target levels for maintenance therapy with lithium should be in the range of 0.5 to 0.8 milliequivalent per liter. Higher levels ranging from 0.8 to 1 milliequivalent per liter are associated with a reduced number of relapses, compared with levels between 0.4 and 0.6 milliequivalent per liter, but also have an elevated risk of side effects. In addition to determining an appropriate maintenance lithium level for RLT, it is important to consider whether once-daily administration of lithium can improve adherence or adverse effects. During periods of dosage readjustment, RLT will require monitoring of his lithium serum level more frequently. Once stabilized, the monitoring frequency can be reduced to quarterly. The next question reads, what other maintenance treatments for bipolar disorder are available should RLT fail to respond to lithium? We will now discuss anticonvulsants. Valproic acid and lamotrigine are reasonable alternatives to lithium that have shown efficacy in bipolar disorder maintenance therapy. In the first controlled trial of valproic acid for the maintenance treatment of bipolar disorder, patients were randomly assigned to receive valproic acid, lithium, or placebo and followed for 52 weeks. The three groups did not differ with regard to the primary outcome of time to any mood episode. However, a lower percentage of patients discontinued treatment for any reason in the valproic acid group, that is 62%, than lithium, that is 76%, or placebo, that is 75%. Patients on valproic acid remained in the study longer, that is 198 days, than patients on lithium, that is 152 days, but not placebo, that is 165 days. The mean valproic acid serum concentration was 85 micrograms per milliliter. Lamotrigine has been studied rigorously in the maintenance treatment of bipolar disorder. A pooled analysis of two placebo-controlled studies found that lamotrigine and lithium more than doubled the time to intervention, e.g., addition of pharmacotherapy or electroconvulsive therapy. For any mood episode compared with placebo, the time to intervention was 197 days for lamotrigine, 187 days for lithium, and 86 days for placebo. Lithium preferentially prevented manic relapses, whereas lamotrigine preferentially prevented depressive episodes. We will now discuss atypical antipsychotics. Atypical antipsychotics have become increasingly popular alternatives and adjunctive treatments for maintenance therapy of bipolar disorder. To date, aripiprazole, olanzapine, quetiapine, adjunctive, risperidone long-acting injection, and ziprasidone, adjunctive, have received FDA approval for the maintenance treatment of bipolar disorder. A meta-analysis evaluated 20 trials, N equals 5,364, in the efficacy of maintenance treatments for bipolar disorder. No monotherapy options were associated with significantly reduced risk for both manic, mixed and depressive poles compared to each other, while the only combination, quetiapine plus lithium or valproic acid, demonstrated significant reduction in risk versus the comparator of placebo in reduced risk for both poles. The long-term risk of side effects, including metabolic complications and extrapyramidal symptoms, should be the primary consideration for selecting one atypical antipsychotic over another. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 551.